New Africa Broadcasting Network.
My name is Dr. Terrence Baker. I'm the host of NABN TV, Doctors in the House. Today we have a distinguished guest with us in the studio, Dr. Anthony J. Cannon, who is a renowned endocrinologist from Temple Healthcare. Dr. Cannon began his training at Cornell Medical School. He continued extra training at Bay State Hospital Medical Center, and then even more training in diabetes and endocrinology at the famed Temple University in Philadelphia, Pennsylvania. Dr. Cannon is board certified in internal medicine. He has additional board certifications in endocrinology and special training in diabetes and diabetic management. He has been the president of the South Jersey Medical Association. He has also has a fellowship in medicine here in New Jersey. He is a special contributor, guest lecturer to NABN TV, Doctors in the House. Join with me and welcome Dr. Anthony Cannon to our program to discuss diabetes and how it affects you in your life. Today we're going to start out with what is diabetes and how would a patient know that they have prediabetes or that they're prone to diabetes.
Yes, diabetes is a disorder of insulin secretion, an inability to make enough insulin to keep blood sugars in the normal range. Blood sugar is most important for energy for the body. Once we're not able to get sugar into the cells, it backs up in the blood and causes a number of medical problems. Our signs and symptoms of diabetes would include increased thirst, increased hunger, fatigue and malaise, and often, if not treated, a loss of body weight. There are many conditions which can mimic diabetes, but this by far are the number 1, 2, and 3 signs and symptoms that we see in our clinic when patients come in uncontrolled with respect to diabetes.
Insulin. What is insulin? What is the process for determining how much insulin a patient needs and if they need insulin or medication by mouth?
Insulin is a hormone that is secreted by cells in the pancreas called beta cells, which serve as a reference for all of us to keep our blood sugars in a range of 80 to 120 milligrams percent. Even when we eat carbohydrates and we have large amounts of food groups, we're able to continually maintain our blood sugars between 80 and 120 milligrams percent. When insulin is deficient, our blood sugar goes significantly above that point. And once we get in a range of 200 to 300 milligrams percent throughout the day, we begin to develop those signs and symptoms we spoke of thirst, feeling very well, getting up at night frequently to urinate, and we begin to lose weight because the body recognizes that sugar is in the blood and not in the cells where it's needed for energy expenditures. The body begins to melt first muscle, then fat, leading to precipitous weight loss in patients who are uncontrolled for long periods of time.
What I'd like to know is where is the pancreas and what does the pancreas do for each one of us?
The pancreas sits literally behind the stomach in an area called the retroperitoneum. It's a big term. It's sort of like an area where it's behind a zipper, protected. It's right in front of the backbone, the midgut, and it actually is probably one of the most important end organs in the body. Its role is to help us with digestive purposes for fats, and it also serves another purpose, and that management of blood sugars. So we have something called islet of Langerhans cells. These are bodies within the pancreas, well protected, that regulate our blood sugar and many other functions throughout the body. The pancreas is by far the center of the universe for those of us who do a lot of work in diabetes. The word diabetes means to flow, and the words diabetes mellitus means let the sugar flow. And this is a good way to remember diabetes. It's a issue of unregulated blood sugars throughout the body.
Next, Dr. Cannon, I'd like to thank you for being with us today. I'd like for you to discuss the difference between type 1 and type 2 diabetes. These two types are something we hear a lot about. Patients hear their doctors talk about type 1 diabetes, type 2 diabetes. Can you describe the difference and the similarities?
Yes, in fact, there are multiple forms of diabetes. There is type 1 diabetes, which generally affects children and young adults, and on occasion, adults in middle age. This is a total deficiency of the ability to make insulin, often post-viral syndrome, some of sick stomach. They have nausea and vomiting, particularly when they're young. If they're genetically susceptible, they can, on the basis of the viral infection, selectively lose the ability to make insulin from these cells within the pancreas, the so-called beta cells. That's a classic presentation of type 1 diabetes mellitus. It is a disorder that is fairly rapid. There are variants of this that perhaps gives you a little bit of what we call a honeymoon before you lose total cessation in terms of the beta cell function. In terms of type 2 diabetes, it's a disorder where you lose beta cell functionality, but you're still able to make some degree of insulin, not enough for your needs. It's also associated with what we call insulin resistance, where the end organs, such as the liver, the fat, the muscle layers throughout the body, are resistant to some degree to native insulin secretion. A third form of diabetes is called gestational diabetes. This is something we see in women who give birth to babies. During their pregnancies, they can lose control of their ability to make sufficient amounts of insulin for themselves to keep their own blood sugars under control based on the pregnancy. And finally, there's something called type 3, which is a little bit more complicated. It's a type of diabetes which has some elements of type 1 and type 2 in association. A significant amount of this finding is in both camps. These people can make insulin, can have some degree of insulin resistance, and it's sometimes hard to delineate if they're in one camp or the other. More often than not, these patients with time begin to look more and more like type 2 diabetics. But those are the major groups of diabetes which we deal with in the clinic.
Besides frequent urination, weight changes, increase in thirst and drinking, are there things that your doctor can do to check you to see if you have diabetes?
Simple blood work, what we call a comprehensive metabolic profile, which looks at liver and kidney function as well as blood sugars, can really delineate the problem. If a fasting blood sugar is in excess of 100 milligrams per cent, we become suspicious in a clinical context of those signs and symptoms. There are people that have prediabetes, which we haven't discussed yet, who can maintain blood sugars in the range of 100, perhaps to 115 milligrams per cent fasting. These are individuals who are on what I call the precipice, where they can develop frank type 2 diabetes, but don't meet the necessary classification of the disorder. They have what's called impaired glucose tolerance. They cannot maintain their fasting blood sugars below 100 milligrams per cent. A person without that risk or risk of having type 2 diabetes would literally, for example, maintain fasting blood sugars in the range of 70 to 90 milligrams per cent. But on occasion, patients come in with other reasons, for the visit reasons, and have spurious blood sugars fasting above 100, but less than 125 milligrams per cent. Many of these patients have what we call prediabetes mellitus, or in some instances, early type 2 diabetes mellitus. This is something we pick up frequently in our clinic when the patients are there for other reasons.
Let's talk about medications. Dr. Cannon, if you would help us to understand the type of medications that patients can take to improve their diabetes, that is, to lower and control their blood sugars. Are there medicines that your doctor can put you on to help control your blood sugars? Are there medications that can be used for prediabetes as well as type 1 and type 2 diabetes?
A very, very important question. With hospitalization, patients are seeing more and more use of steroid preparations for other reasons. This is called steroid-induced diabetes. And this is something we get consulted on a frequent basis. People without any knowledge of even pre-diabetes, they appeared to have been quite normal prior to the hospitalization, get intravenous steroids, leading to consultations on the endocrine service um, for the basis of having very high blood sugars. It can be quite explosive, to be frank with you. There are some people who otherwise didn't know they had underlying type 2 diabetes mellitus, but based on the use of steroids and other substances that we use that antagonize insulin function in the body, the patients are remarkable for blood sugars well above 200 to 300 milligrams per cent. That's true. I would say 20% of my consultations in this realm are on a basis of steroid-induced hyperglycemia.
Are there medical conditions that can make you prone to getting diabetes? Also, if you would teach us, are there medications that your doctor can put you on that might cause diabetes to occur?
The most important findings that I have in my clinic is surrounding one topic, obesity. We're speaking about a generation of people suffering from what we call diabesity, the combination of diabetes and obesity. These are patients with type 2 diabetes who come in with progressive weight gain and worsening blood sugar control. I often tell my patients, pick your grandparents more carefully next time. We have multiple generations of individuals who have type 2 diabetes. I have a family right now with 10 siblings, and 9 of the 10 siblings have type 2 diabetes. 80% of those siblings have either morbid obesity or obesity as a confounding variable. The genetics here are complicated in type 2 diabetes. I look at type 2 diabetes more of an environmental disorder with some genetic overlay, unlike type 1 diabetes, which is generally looked upon on a genetic basis. We have a number of people who have had gestational diabetes who go on with weight gain beyond the pregnancy to gain the title of having type 2 diabetes. In African American women, for instance, 40 to 50% of them in a 5 or 10-year time period will go from gestational diabetes with 1 or more 2 diabetes mellitus. The confounding variable there is relative weight gain and frank obesity. 85% of those people in our country who have type 2 diabetes also have obesity. There are a group of people up to 15% relatively lean who can develop type 2 diabetes mellitus. And their modeling appears to be severe insulin resistance. They could have near normal insulin levels, but yet not have normal blood sugars because the tissue level, the organ level is resistant, acquired defect, a resistance to native insulin.
Dr. Cannon, we'd like to continue our discussion today by looking at new onset diabetes. And we want to discuss how a patient might know that they have diabetes. What are the common signs and symptoms? That is, how might a patient feel when they're beginning to get diabetes? And are there certain risk factors like gaining weight, the diet that you drink, the diet that you consume, that is the beverages you drink, the food you take in, that can affect the sugars? Later in this program, we're going to have an exercise physiologist talk to us about exercise and the role that exercise plays. We're going to have a dietitian talk to us specifically about nutrition and hydration. But can you tell us from a medical point of view, from the physician's point of view, what are some of the risk factors for developing new onset diabetes and things that you can do to reduce your risk?
That is a very fair assessment. In fact, the African model, as I reviewed the database, is complex, much more complex in America. And the realization there is you have mitigating factors of starvation, undernutrition. You have a relatively young population of individuals who are developing diabetes, type 2 diabetes specifically, at a much earlier rate than we see here in America. You also have a variant you speak about with the westernization of the African countries. If you go to the capitals of many of these countries, you find the Western model. I call it overnutrition, to not eat the types of foods that we eat here We see the same thing in other parts of the world, such as the Asian continent, specifically India, Pakistan, and Bangladesh, where the largest cities, if you look at the explosion of diabetes, a lot of it is the westernization and change of native eating habits and westernization in terms of eating habits like we do, eating highly processed foods. These foods can diabetogenic in some instances. So I see the African continent sort of as a potpourri of different forms of type 2 diabetes. We also see something, if I can describe this to you, in Africa, more than we see here, and that is the development of ketosis, the concept of having acid build up in the blood, uh, leading to diabetes. These are relatively lean individuals who have ketosis prone diabetes, where they can look like type 1 diabetes, where they look like they have little or no insulin secretion, but indeed they do, diminished. We can reverse this with short-term use of insulin. These people are prone over time to have all the caveats of type 2 diabetes that we know later on in life. But in early life, in your teens, in your 20s, and your 30s, they can come in with this variant called ketosis prone diabetes, where for all practical purposes, they look very much like here in America, those with type 1 diabetes mellitus, but they are able to recover, at least for a period of time, come off of insulin and may not require oral agents in the short term, but the long term, they will eventually need oral agents and or insulin.
I want to thank you for being with us today. Before we conclude our time together, I wanted to ask you a question about COVID-19 and SARS-CoV-2. And do you anticipate, as a result of this pandemic, that we're going to see more diabetes, or that we're going to see more diabetic problems? What are you seeing in your practice?
The COVID-19 pandemic has unfortunately made evident to us the disparities, the health disparities in this country. We have African Americans at significant risk for having type 2 diabetes. In fact, 13 to 15% of African Americans above the age of 18 have type 2 diabetes. They have disproportionate representation for hospitalizations and poor outcomes. Up to 30% of individuals who die as a result of COVID-19 are African Americans. And it has to do with the lack of control of diabetes type 2 prior to the infection. I want you to think about diabetes as a pro-inflammatory state. There is inflammation throughout the body that's related to high blood sugars. It tends to make us somewhat immunocompromised in the sense that our immune system is not compensatory in a sea of blood sugar above 250 milligrams percent. Individuals who come into the hospital like this, who then are given steroids intravenously and other medications, tend to have an explosive form of COVID-19. In fact, we are now looking at data on a race and ethnicity base that demonstrates a selection of African Americans for poor outcomes once hospitalized, once given ventilation through an intubation intensive care unit, and having a markedly increased mortality as it relates to this disease. This is a very discriminating disorder. People of color in general are at greater risk for bad outcomes. What people don't seem to understand is that there's a disproportionate number of African Americans who get the COVID for a number of socioeconomic reasons. Many of our people are first liners. They're people walking, in my analogy, across the railroad tracks with a fast moving train very close. You can sometimes get across the tracks, other times you're caught. It's very frustrating to see how sick our patients are coming in and how poorly they do. I see a very distinct relationship on race and ethnicity based on the COVID-19 model.
Dr. Cannon, we'd like to thank you for being with us. Today we've had the chance to meet with and interview Dr. Anthony Cannon, who is a well-known endocrinologist, a specialist in diabetes. We'd like to thank you for being with us today and answering our questions and providing an education. We look forward to having you back on the program soon. Thank you, Dr. Cannon.
NABN, New Africa